Hey, Roopan, welcome to the show.
Hi, Brittany. So excited to be here.
I am so honored what you just said right before we clicked record. Can you tell people what you listen to when you run?
Oh my God. Yes, I was just telling Brittany that I fangirl her and FemTech Focus. So between FemTech Focus and Michelle Obama's podcast.
Yes, y'all. I just want to take a moment and tell you how good I feel to be in the playlist with Michelle Obama. That's amazing.
Oh my gosh, yeah. It just motivates me. It's like a ritual every week. It's like, okay, got to get my FemTech Focus podcast in and my Michelle Obama podcast in.
Oh my God, it's amazing.
Brittany Barreto and Michelle Obama.
Oh, Michelle, please reach out to me. Be a friend. Well, that is seriously so kind of you, because I honestly am just a lady who likes to say vulva and fight for women's rights, and so here I am just recording. You now know the secret sauce. It's just me on Zoom. So listeners, I like you to think that this is professional. It's totally professional, but also you can grassroots anything, y'all.
Totally.
Yes. Well,
there are a lot of things in common between you and Michelle.
Oh, really?
Obama. Yeah. I mean, the things that we talk about, like she has one episode that's all about women's health and all about how we need to talk more about women's health and menopause and periods and our menstrual cycles. And she's also this badass reproductive health and all women stuff activist. So
she would love the show. She would love this show then.
Yeah, I think so.
Well, our listeners love to learn about our guests and their background. So why don't we kick off our interview with you telling us where you're from, what did you study, what's happened, and how did you end up here working in women's health?
Yeah, awesome. So, basically I'm an obstetrician-gynecologist. Canadian, born and raised here, but I am actually of East Indian descent, first generation immigrant. Was brought up actually in a really small town in Ontario in Canada. You could say it's rural, and went to an all-girls school and grew up in a household that basically we didn't really talk much about sexual and reproductive health, and particularly because of my background as well, being of East Indian background, it's very taboo to talk about sex and talk about reproductive health. And then even more so to talk about abortion and contraception.
Yeah.
Interestingly, I'm trained as an obstetrician-gynecologist, but I also, on top of that, I'm subspecialized in family planning. So that involves complex contraception and abortion care. And I think my parents, it's very interesting because they probably, we don't really sit around the dinner table really talking about what I do day to day. Even for Vitala, like I showed them the website and they're like, wow, this is great. But like, I think
they're like, let's not talk anymore about it though. Yeah, like, that's enough.
Exactly. They're like, we're very proud of you. Yeah. And then, we talk about something else. So interestingly, so I did my training in obstetrics and gynecology in Canada and then pursued a 2-year subspecialty in family planning. And I do want to give a shout out to this family planning fellowship because I was the first Canadian fellow to go through it, but it's actually an American-based fellowship. So a lot of my co-fellows, and now it's become an accredited fellowship in the US, and some of my dearest friends are abortion providers and family planning providers in the US fighting the good fight. So I just had to give them a shout out.
Yes, shout out to y'all. I actually am very vocal, especially recently, because I've been in the femtech industry long enough now that I'm actually pretty pissed off that I haven't seen any panels on abortion. And I'm like, okay, y'all, like we're all edgy and stuff and talking about sexual wellness and vulvas. And we're all like, we don't care if you don't like it. Women's health matters. And I'm like, well, where's the abortion panel? Because that is innovating, let me tell you. All right. So anyways, yes, I hope we can talk more about that, but it's something I'm very passionate about.
Oh my God. And I love that you just said that. Now I'm like fangirl crushing on you even more. Like, honestly, even, I was like, there's such a need to talk. That's why I'm so excited to be here today to talk about this. But yeah, so I grew up in Ontario. I did my training all around Canada. I did my master's of public health and global health and population at Harvard. You know, I grew up in a household that was very female strong. Like my mom, you know, my parents are in business. And I think that we grew up with that whole like business mind mentality that now has led me into this like sort of startup, not-for-profit, like leading my own thing, which has been really, really interesting. I've also, so did all the training, but my trajectory, or how I would describe myself, is that I'm, you know, an innovator, a clinician, and a researcher. And so I've spent a lot, my spirit is a bit free because I do love working and traveling around in many places. So I've done a lot of things in global context, very focused on sexual and reproductive health and rights in places like Uganda, Malawi, Lesotho, Tanzania. And most recently, after I finished my fellowship training in the last couple of years, I spent time with Médecins Sans Frontières, Doctors Without Borders, as an emergency field obstetrician in Nigeria. And then most recently, I actually was in Yemen since January 2020 and just got back in June, was stuck there because of COVID.
Wow.
Yeah, so that's a whole thing we can talk about as well. And it's another hat I wear. So I have my Vitala hat, but my MSF hat is a big one too, because now I've most recently taken a position with MSF France, their France section, to be their women's health advisor for OBGYN.
Wow, dude, you're a big deal. I knew you were a big deal coming into this episode, but yeah.
Yeah, no, but it's all interconnected. I hope, like, as I share my stories, that it makes sense, because sometimes I'm like, you know, I wear these multiple hats, but they are all interconnected, because even and I feel like they're interconnected in what we're doing with Vitala, with the abortion piece and the global health and the challenging contexts. And then the other piece, I guess, about my story is that when I did my first mission with MSF, I moved to Geneva, and I was working with the WHO as medical officer with them for a year. And that was with their Department of Sexual and Reproductive Health Research, Preventing Unsafe Abortion team. And and then while I was there, I decided that I needed to be back in the field. I wanted to be with that's why I went to Yemen. I wanted to do my own thing too. Like, I was like, I need to get on my own 2 feet, and I wanted to start my own thing, which I hope I'll get into that a little bit more, of how Vitala seed started to percolate. But
do you think that the World Health Organization is kind of like a theoretical, it's like policy, theoretical thinking about it type of thing, less in the trenches?
So yes and no, because it's so interesting. Like, I feel from headquarters standpoint, yes, because you are, in Geneva. That's where I was, in the headquarters in Geneva. So it is like more the policy and developing the norms and standards, developing the guidelines, bringing the evidence together. But then when you go to the country offices, that's where you feel like there is a little bit more of the sort of nitty gritty in the trenches. But again, it's not like MSF. MSF is like that, you're
out
in the
there.
trenches.
Yeah, no borders.
yeah, exactly.
Yeah, no borders.
Exactly.
Wow.
Yeah.
So when did you start Vitala? What's that story like?
Yeah, so Vitala stories, it's interesting because it's been an evolution, and it's organically growing. Now, the organization Vitala itself was incorporated just in May of 2020, but its inception and the whole story started in 2016. Yeah. So when I was doing my fellowship in Vancouver, that's where I did my fellowship in family planning. As part of that 2 years of training, you get X amount of money. You actually, their whole premise is to train you to be an academic family planning practitioner. And so you get funding to run your own massive research study. And I was super curious at that time and I think in the last decade, I've always been very curious in my research, and the way I do the research is to really understand what is it that women and girls need, particularly when they need to access sexual reproductive health services, but more so, especially on areas that are stigmatized, like abortion, family planning. So essentially at the time, so when I was a fellow, I was like, okay, I've done research already in this space of using qualitative methods, really trying to understand women and girls in their context. And not only collecting the data, but then thinking of how can we use that data to develop an intervention. And for me, that intervention that I'm quite interested in is in the digital space. And that is come from, and the reason why I've been really interested in the digital space is because of all the global health experience I've had. Because you go to all these places, and in the most rural and remote areas, you have someone with a cell phone. Wow. And they have swanky smartphones, like Yemen. They're like in an active war zone, and they would have, you know, these like nice cell phones and smartphones and have Facebook and have WhatsApp.
Oh, yeah.
Yeah. So when I did this fellowship project, and the idea was that I wanted to truly understand how Canadian women, so this was in the Canadian context, how did they feel after they've had an abortion? Did they feel supported? And if we were to design a digital tool with them, would that be something that would be feasible? So fast forward, we conducted this rigorous research study. It was, 3-phase design, user-centric, very data-driven, used a lot of design thinking principles, and designed My Post Care, which is the tool for Canadian women to support them after they've had an abortion. Lots of people were like, hey, this is so great. Like, you could do more with this. You could even sell this. You could create your own company with this. Mm-hmm. I was like, okay, a little overwhelmed because it was like meant to be a research project. Yeah. And then I kind of put it on the shelf, but we were still working on it, percolating, because then I went to WHO and I started doing a bunch of other work. And also, to be honest, and this is one of the challenges I've been facing, is like around funding. I had funding for that as my research project, but then we didn't have, like, I only had it to a certain point, and then I didn't have it. So, we're kind of working on this at the side of our desk afterwards. Then when I was at WHO, I was starting, starting to think, okay, like and more signs were coming up, people, data was coming out to say that there's this massive gap in terms of abortion care to support women. A lot of data was starting to come out, and already was out before I even got to WHO, on this whole self-management and self-care movement, which is that abortion is so safe and so effective if women and girls are given, and I'm using women and girls, but we do say pregnant persons and being very gender inclusive, but that they, if they're given the right information, they can actually self-manage their own abortions on their own. They don't need a specialized healthcare provider. They don't need to be in a hospital setting. It can be done in a community base. It can be done in their homes. I've done in a supportive.
Oh.
Yeah, and totally safe, totally effective. Even WHO recommends it. So then I started to think to myself, I'm like, wow, okay, I was already doing the self-care stuff. Like, My Post Care was all self-care. It's all about empowering women after they've had an abortion to engage in their own self-care. And so what was great is that Grand Challenges Canada comes along in the winter of 2019 and says, hey, we are doing a call out. And they had basically, they were, giving out grants, focus on abortion in low and middle income countries.
Wow.
Yeah. And I said, oh my God, this is my chance. Like, I should apply for this grant and use it as seed opportunity, like seed money, to go for it and create this organization. But it was interesting because it was just me at the time. Vitala was just me. And at the time we weren't Vitala, we were RKG Global Consulting. And I basically applied for the grant. I incorporated myself. The incorporation came in like literally a day before the grant was going in. And then that was it. And I got the grant. So I applied for it, and then months go by, and there was over 300 applicants, and only 19 innovators were given this award for this first round. And so I was one of those. Wow. And then Vitala, basically from there, it just accelerated, because Grand Challenges Canada was so supportive. They said, listen, like, initially they were like, you didn't pass the due diligence because you're just one person and you don't even have any policy. So I was like, oh my God. Okay. I was like, I have to hustle. So I created my human resources policies. I got a board of directors together. I did like my finance policy, my fundraising policy, put it all together. And then my best friend, who's now like one of my really good friends, Jen Tam, who's also my co-founder now, we start talking. So she starts to help me and becomes my project manager. And then it just organically just propelled and evolved in a way that we became more official. And we realized, okay, and sorry, I should say, the grant that we applied for with Grand Challenges Canada was to design and develop a digital tool to facilitate self-managed abortions for women and girls in Venezuela. And this, yeah. And so that actually allowed us to put our passion and our expertise in the safe abortion space and the humanitarian setting together, as well as the research and clinical piece all together, and work with amazing partners like the grassroots organizations that we're working with in Venezuela. And so we essentially are now basically like a design thinking organization that is multidisciplinary, that co-designs these digital solutions to support individuals in these challenging contexts to self-manage their own abortions and family planning needs.
I am seriously so honored you're on the show. And wow, this is really, really important work. I have a lot of questions.
Yes.
So, and I always imagine if I have a lot of questions, I bet my listeners do too. So my first question is, what is a self-managed abortion? So when I think abortion, I had an abortion, so I always think of what I had, right? And so maybe people have paradigms of their experiences too. So can you talk to us about the different types and what is self-managed?
Yeah, for sure. Thank you for sharing that, Brittany, as well.
Most women have had them.
Yes.
And
I'm so glad you said it.
On this international podcast.
Yes.
You know, like I made a choice and
I love it. And also I was going to say that honestly, like it's so fascinating because some people don't realize it, but when I share stats and I say, listen, people, 1 in 3 women have an abortion in their lifetime.
Yeah.
1 in 4 women have a miscarriage. These things, like, we need to talk about them. We need to kind of bring it up. And that's why Vitala was started, right? And it's ridiculous because to me, I think, and for us now as an organization, we're like, it is such a preventable it's so preventable in the terms that we have this amazing technology that people can use, yet it's one of the leading causes of maternal mortality in the world.
Yes. Yeah. And probably, I mean, you're the expert, but I'm assuming it probably has something to do with us not talking about it. The fact that it is shocking, you know, if I talk about my period on this, people are a little uncomfortable, but if I talk about I had an abortion at 22, people are like, oh,
yeah,
get that. And it's like, yeah, 1 in 3 women, you know.
1 in 3 women. Yeah. And, you know, 22,000 women die per year from an unsafe abortion. So we're very lucky that we have
to talk about it. We got to talk about it. Yeah.
We got to talk about it. Totally. But sorry. So just to come back to your question about self-managed abortion. So what self-managed abortion looks like is that, first of all, I should be very clear that it's about self-managed medication abortion. So it's with the pills, and it can be and the pill there's 2 pills. There's mifepristone and misoprostol. And then in some settings where you don't have mifepristone, the alternative is with misoprostol alone. The effectiveness of doing it on taking the pill, it's like almost 100% if you do the combination with mifepristone and misoprostol. And essentially when we talk about self-management, it's that we are saying that an individual who's seeking abortion can actually self-assess for her own eligibility, meaning that she can assess that her gestation, like she's the weeks pregnant that she is eligible for a medication abortion, along with assessing that she doesn't have any reason to not be able to take the pills, and that she can then self-administer the pills on her own, and just does not need to be done in front of a doctor. It does not need to be done in a specialized healthcare facility. She can do it in the comfort of her home with the support person of her choice. And then finally, it would be that she can actually assess for the success of the completion, success of the abortion on her own as well. Yeah. But throughout this, underlying the whole thing is that individual needs to have the correct information. Yeah. That information can be provided by abortion hotlines. It can be provided by a community health worker. It can be provided by a midwife or a nurse in many of these sort of low resource settings. But the individual herself doesn't need to be in a hospitalized situation. So she can actually go through the entire process.
Yeah. So the pill, how much pregnant can you be and still take it? Like, is there a line where you can't take the pill anymore?
What a great question, Brittany. This is like something we in the abortion community we discuss. So no, people are doing with mifepristone and misoprostol. You can do it at any gestational age. However, what I will say is that, and just to be very, very clear, is that it's all about sort of the evidence that we have in terms of how effective and safe it is. So as someone is more pregnant, it does lead to a little bit higher complications, and it may not be as successful.
Yeah.
Whereas and so the evidence, and when we actually recommend it, and also when it's recommended as per the WHO, it's up to 10 weeks, because that's what the evidence tells us. And now in the abortion community, there are more people and amazing researchers that are doing the work, and actually, because we need the data to say doing it in the second trimester is okay. Like it's also safe and effective. And some people want that. They still want to be able to do it in the comfort of their own homes.
Yeah. Because the alternative to the pill, so let's say second trimester, current data is out. We don't know yet, right? So we're thinking this individual pregnant person needs to go in somewhere. So what is that abortion called? That kind?
Right. So if you say, because there's so many reasons why a woman also needs an abortion, because it might be that the baby has some anomalies, or there's, or it's for choice, that she wants the abortion. If it's after the first trimester, so like sort of after 12 weeks, again, you can do it with mifepristone and misoprostol, but we also can do it by manual vacuum aspiration. So it's basically a suction device that is used, or the more advanced the procedure gets, then we do dilatation and evacuation. So it's actually a surgical procedure. And those cases when it is required that you do a dilatation and evacuation, and that's what individual chooses, that then requires you to be in sort of a procedure room as well. But again, it doesn't require you to have all the general anesthetic and all that kind of stuff. It can actually be done with conscious sedation, and again, in a very sort of minimally invasive way.
Got it.
Yeah.
So you said 1 in 3, let's talk some statistics here.
Sure.
So 1 in 3 women, is that a US number, have had an abortion?
That is
worldwide?
That's worldwide. Worldwide.
Wow. All right. So 1 in 3 women, do you know the total number that is, or like how many is that a day, or however, like?
I know, that's actually such a great question. I actually don't know, but it would be like per day. I would have to look into it. But I mean, I can say from my own personal experience, when I was training to be, and I even as a provider, both in the Canadian context and then also in these humanitarian settings. So for example, when I was doing my training, we would have in the abortion clinic, you have about 10 to 12 people coming every day for an abortion. But that is based on us being able to accommodate for them, right? So there's a lot more people who need it. And I will say with COVID-19, there was actually a really nice modeling study that Guttmacher came out with, saying that if we have even a 10% decrease in abortion-related care we don't do it because of COVID-19, it could lead to 3 million more abortions that are needed.
Wow.
So it's so it's a
necessary procedure. It's happening a lot. This is not, why Venezuela? What is it about that country that needs support in this way?
Yeah, I just love your questions so much. Okay.
They're genuine, listeners. We have a set of questions. I have not asked most of them. These are genuine questions.
No, it's great. So I mean, there's 2 pieces to this. So the one piece was why Venezuela. First of all, it was more of a personal thing, in the sense that when I was at the WHO and I was applying for the Grand Challenges grant, and I wanted to go and go on it on my own and actually do something that's in a humanitarian setting related to abortion. I was so lucky because I was connected to friends and colleagues that came to me, and they were like, hey, we know you did this work in Canada. How about we partner together? And particularly, like, I had a dear friend and colleague from IPAS, which is a great organization that does abortion-related work. And she came to me and then connected me to International Planned Parenthood Federation, Western Hemisphere region. And so then I then got connected to the SRHR or Sexual Reproductive Health Organization in Venezuela, who then said, yeah, we want to work with you. We really love your idea. And we also thought, okay, why Venezuela? Well, first of all, there wasn't very much data coming out of there. And honestly, sometimes I'm like moved to tears when I am analyzing our data and looking at our user interviews and the survey and I'll share a little bit about that as well. But there's not that much data that's on sexual and reproductive health, and particularly abortion. It's one of the highly restrictive settings, meaning that the abortion is illegal, but only to save the woman's life. There's a complex humanitarian emergency that's occurring there that is leading many women to seek unsafe abortions, which we found also is, in our data still, so 30% of our respondents had an abortion or in Venezuela, and then of those, still 20% used some sort of an unsafe method, despite the fact that there is misoprostol available in Venezuela. And then the other piece of it was that the cell phone. So we know, like in Latin America, from our data when we were doing sort of a background landscape analysis, that there is a high, a lot of people use a smartphone, and a lot of people use WhatsApp and Facebook. So we had to think, okay, if we're going to design a digital tool, we should do it in a place that we also know that it will be feasible, just from a digital health standpoint.
Why? Sometimes I ask questions because I'm genuinely have no idea what the answer is. And sometimes I ask questions because I'm like, this needs to be on record. This is one of them. Why do women need or want abortions? Like, why would a woman in Venezuela do this?
Right. Yeah, no, such a great question. There are so many reasons, right? And just actually yesterday, I was having this conversation with another friend of mine who's a provider, and because we always have this dilemma too, like, as providers, does it really matter why someone comes to have an abortion? Like,
as I was asking it, I was like, the answer should be like, who gives a fuck? It's a woman's body, but nevertheless,
but I think it's really, but it's also good to like shed light that there's such diverse reasons that it's not, like there could be so many reasons. So for example, in the Venezuelan setting, we have, you have all of sort of these young people. For example, there's a very high rate of unplanned pregnancies or adolescent pregnancies in Venezuela. And then on top of that, when you layer on the economic crisis, like they don't have, since between 2012 and 2017, their number of contraceptives decreased by 92%. What? In the country because of the economic crisis and all these things.
Oh,
and then
my God.
Exactly. So one reason is that they don't have access to contraception, and so they get pregnant and then they need to have an abortion. You could have another circumstance where they've already had a pregnancy before and they don't want to have a second pregnancy. They're in school and they're like, I don't want to be pregnant right now, and I want to continue with my schooling. You could have some people that come because they have a pregnancy that's not healthy. There's a fetal anomaly or something like this. And what I mean by fetal anomaly, just for the listeners, is like, things that basically that would be wrong with the baby. And then there's just like a whole host of other reasons that, it's irrelevant in a lot of ways. But a lot of it is around their social, economic. It could be their cultural circumstances. Like in my own community, I know, like, because talking about sex and reproductive health is so taboo. We can't even say or talk about the fact that in our community, people are having sex before marriage.
Yeah.
So sometimes like a woman will get pregnant and she's young and she needs to have the abortion and her family can't find out about it. Right. So there's so many reasons. And there's a lot of data, and there's a lot the people in my community, like the abortion community that I have so much respect for, that are researchers in this space, have really looked at that and especially in the US, why women make the decisions that they do.
Well, you just said there's so many reasons, it's very diverse, but what I did not hear you say is that it's a convenient and great way to have birth control. And I'm so happy you didn't say that, because over the past few years I've gotten more and more vocal about my experience having had an abortion at 22. And for me, I was in college, and it just wasn't part of the plan. And I was with somebody who wasn't sure. It was like my first real boyfriend in college. And it just, that was my route. But when I had the experience and I had the aspiration one type of abortion, and, afterwards, it was freaking hard in terms of like, it was not a pleasant experience. There was no support afterwards. And so what I'm getting at here is that now when I'm more open about it, the biggest thing I hear from people who are anti-abortion, essentially anti-choice, the biggest thing I hear is that they say, well, I just don't like that people use it as a form of birth control. And I want to very firmly hold this person's shoulders and look them into the eyes and say, nobody is doing this on a Friday night casually every week because it's just so convenient. Yeah. I promise you, if you went to a clinic, if you had this experience, if you had a friend that you helped out, you would know people are not just casually, quote unquote, murdering babies because it's just more convenient than a condom. Like, I promise you, no one is doing that. Can you confirm this with me?
Yeah. It's very interesting because it is not a decision that people take lightly, right? And this has been definitely a debate back and forth in our community about, is it a form of family planning? Because some people actually, and I know I've listened to others of your episodes because we also need to innovate so much more in the family planning and contraception world, because I think we're still limited and that there's not enough options for women in that sense. So some may not use birth control, or they use fertility awareness-based methods and then get pregnant and will have multiple abortions. My opinion on that is that is fine. It's up to her. We don't know, like, every individual's decision of why she wants to do what she needs to do is her decision. But I will say that it's definitely not a decision that's light. And I also think that because I work in two different contexts and I see the implications of the stigma around abortion in places like Venezuela and many places in Africa I've worked, in places like Yemen, no woman should die from an unsafe abortion in this day and age. And then when people do say, oh, well, it could be like a birth control, like, for example, in Venezuela, because of the restrictive law, and actually we have good data to support that, though in places where you have more restrictive laws, it actually doesn't mean that people have less abortions, because there's that assumption if we have a restrictive law, then people will have less abortions. It's not that they have less abortions, they still have them, but they are put in a situation where they have to do them unsafely or in a clandestine manner.
Yeah.
Go ahead.
What are some of the forms of unsafe abortion, right? I hear this like horrible thing about hangers. Like, is that real? Because sometimes I talk about things that I'm like, oh, this is a paradigm. And then the person tells me that's not real. So hangers, and like, what are other ways that women are doing this?
No, it's like, it is still, people are in a lot of these settings. Like, I mean, if I have stories, when I think about my experiences when I was in northern Nigeria, when you have patients coming in with septic abortions, that they've put some sort of instrument up into the cervix and into the uterus, or because they're so desperate to end the pregnancy. Other things like in Venezuela, for example, it could be teas and herbs and malt, cinnamon, just all of these sort of traditional types of methods. Coat hanger, definitely. We heard it in some of our user interviews that has happened. So it still occurs in this day and age. And I think another piece of the situation around abortion in many sort of low and middle income countries is also the role women have, and that they don't have the same sort of they're not as empowered or don't have the same autonomy to make their reproductive choices. Mm-hmm. And so they don't have, it's just even negotiating condom use or negotiating contraceptives. So they are actually in those settings, in a lot of settings I worked in, women are having like 7, 8, 9, 10 pregnancies.
Wow. Yeah.
It's challenging. So Yeah. And so, I mean, I love that we're having this conversation in this way, because basically what you're highlighting is why Vitala exists.
Mm-hmm.
There's no one, there's no one like us that's doing this type of work, because we've chosen difficult places and a difficult topic,
Yeah.
but we're trying to do it in a space that is merging the activism and the academia and the corporate, not corporate, but like, you know, the femtech space. Like we're trying to bridge all of that together and say, we can do this in this space, so that we can like actually normalize the conversation and it not be just for the activists to talk about.
Yeah. So what are some ways for women to have self-care around this family planning option? What are strategic ways? Because I didn't experience any, right? And there's no other resources out there. So what are some ways that you're helping women?
Yeah, no, it's yeah. So I loved what you said about, because it just reinforced again, a lot of what we've been hearing from people around, not only in Canada, but everywhere. And I've had so many people now that they know that I do this work, like I'll have a coffee with someone and they just like tell me their story. And I'm like, wow, it is so important that we are actually doing this, that we're doing this work with Vitala, which is essentially developing tools to support them through their journey. Mm-hmm. And everybody like we hear from says that like women need to be reassured in the moment of an abortion. They want to be able to talk to someone who's informed. They want to be able to ask questions and hear advice. They want to basically not feel isolated and feel guilt. And that came up a lot for us when we developed My Post Care, and now what we're developing for Venezuela. So in terms of what types of ways that we can facilitate self-management or self-care, Vitala is doing it in the way that we're co-designing this digital tool. So in Venezuela, we're actually developing a mobile app that we hope will also integrate a WhatsApp chatbot AI type platform that acts like a coach. And that coach will take you through the entire process, from assessing yourself, if you are eligible, to assessing completion of the abortion, successful completion. And then through that, we also provide these notifications that essentially say like, hey, we're here for you. And we're, you know, this is what you can do if you're having a lot of pain. And this is what you can do if you have this amount of bleeding, and kind of educating as well as we're providing the support. And then My Post Care does the same. So My Post Care is a digital web-based platform that we designed that includes like an emotional support tool, contraception tool. It includes the sexual health piece to it, post-procedure signs and symptoms, and automatic email notifications that individuals receive, which also is about supporting them through the journey. And it's about, they're timed 1 month after their procedure, so that and actually our data from those studies are published in two parts of the study have already been published. And a lot of people said it kept them out of the emergency department when they used My Post Care. They did it with their partners. They went through the entire website. They couldn't believe that a digital tool was like a rock for them after they had an abortion.
Yes.
And then so we're, you know, Vitala is doing this work, and we're trying to innovate in the space of creating support tools. Mm-hmm. But I will also say, like, there are other organizations that I have immense respect for that are doing this work as well. And we're just another tool in this toolkit. So we have Women on Web. So they do a lot in terms of providing abortion advice online, and they're more of a service provider in the sense that they will send the pills directly by mail. Okay. Mm-hmm. There's places in the, you know, Access Aid in the US does this. We have there's a program in the US called CARE. I'm pretty certain it's CARE, and they do abortion pill delivery. There's telehealth methods. Mm-hmm. A lot of telehealth that's happening now in the US, especially after COVID. So all these restrictions that were there before are now being removed. Telehealth in the UK, telehealth in Australia. And then Women Help Women is another organization as well that is doing this work as well. So there's a lot of online virtual health stuff happening, mm-hmm. To really help and support and facilitate so that women can access care no matter where they are.
Yeah. Well, you know, with my experience, I felt like I had the access to get it done, but I didn't have the support beforehand or afterwards, right? The emotional support, because I didn't want to talk to about it. I like told my mom and my partner at the time, you know, and that was essentially it. And I didn't even know what are the things I should be considering, beforehand. And then I actually had this paradigm that when you have an abortion, you regret it for the rest of your life, because that's what I always saw in movies and shows. So I was like, am I ready to carry this burden for the rest of my life, that I'm going to be sad about this like unborn child? And then, afterwards I felt guilt because I never manifested that shame. And where I've come to is like, I looked at all the data, right? I'm a scientist. Even back then, I looked at all the data and I said, this is the best choice for my life. And you know what? It's just my experience that I haven't carried around a bunch of guilt and shame, and I shouldn't have guilt and shame about not feeling guilty and shame,
Totally. Yeah, no.
Yeah.
And and the more that I hear about it, that's what actually gets me up in the morning, because I'm like, we are doing something that other people have not done. And there is a space here and it's very interesting, because I think people haven't done it because it doesn't, because I sometimes reflect on this and it's like, oh, maybe it's not as sexy, because it's like emotional support after abortion. But honestly, I think it's sexy. So it's like, because when you hear the stories and you see the implications of the lack of support. And I also think by proxy, if we work in this space and we start talking about it, it will also, we ultimately want to do this. Our vision is that we take it out of this space of stigma, that it becomes normalized, that it's like abortion is just like other things that women have to, like, that they need, that they go through, right, in their lifetime.
Yep. Yeah. Oh my gosh. Thank you so much for the work you do. I can obviously talk to you for a long time. And thank you for, just having this really authentic conversation with me. I know our listeners always appreciate it when it's just real talk, right?
Yeah, totally.
Our last two questions real quick, as you know, as a listener yourself, the first one is, we have a lot of aspiring entrepreneurs. If they wanted to innovate something in women's health and wellness, what is an area you think still needs working on?
So, well, it's, I think more investment and commitment towards these types of stigmatized issues. Mm-hmm. So particularly comprehensive abortion care. And also, because we didn't really get into it, because this is another area that we're working on, is the early pregnancy loss side. So the miscarriage management. Miscarriage is also another big piece, and it's in that umbrella, because many people are isolated and just expect to like deal with it, that it's something that happens. I also think we need, just work on normalizing conversation around these topics. And I think if in the FemTech industry we could do that, and we could get more people innovating in this space, and not having silos, that it's just like abortion happens amongst these grassroots activists only, or it happens with the academics. I would love, like, Vitala, because our goal, our vision is that we become that organization that people see that we're bridging that. We are that sort of organization that bridges the activism and the academia together.
Okay. I love it. Thank you so much for your time today. I am so impressed. And if FemTech Focus can help you in your efforts anyway, we would love to.
Oh, thank you so much, Brittany. It is such a pleasure to meet you and have this amazing conversation.